series for the year 2024. Before we begin, let us start with the recitation of Surah Al-Fatiha. Ameen, Ameen, Ya Rabbal Alameen. My name is Sarah and I will be your moderator for today. For your information, these webinars are a collaboration between University Science Malaysia, International Islamic University Malaysia, University Sultan Zainal Abidin, and University Malaysia Sabah. This collaboration aims to be a platform for continuous education, especially in the field of refined interpretation and assessment. And we hope that in the future and now, we will be able to bring this webinar regularly so that everyone can benefit from these free resources. We are also proud to announce that our webinars have actually reached the neighboring countries, and somewhere in this year, we will have our speaker from Indonesia as well. So before we proceed, there are some housekeeping announcements. Firstly, I would like to ask yourself to keep yourself muted. And secondly, you can ask the questions from the speaker directly during the Q&A session, or you can also type in your questions in the chat box. Thirdly, there are attendance links, and this attendance link will be posted in the chat box periodically. So I would like to ask everyone to please fill it in because we need the details for the CPD applications. Lastly, there are previous PowerPoint slides from our previous webinars, and all of these slides can be accessed through the link in the feedback form. So please do click on the attendance link, okay? So without further ado, we are very actually honored today to have Associate Prof. Dr. Yusni Rahayu from University Putra Malaysia as our first speaker for 2024. So a little bit of introduction about our speaker. Associate Prof. Dr. Yusni Rahayu is an Associate Prof. At the Department of Pathology, Faculty of Medicine and Health Sciences, University Putra Malaysia. She received her medical degree from University Malaya and her Masters of Pathology from University Kebangsaan Malaysia. She was also a visiting academic fellow at the University of New South Wales, Australia. Associate Prof. Dr. Yusni is a distinguished lecturer and researcher with many publications and many grants under her belt. So we are truly, truly honored to have Prof. Yusni as our speaker for today. So without further ado, I would like to invite Associate Prof. Dr. Yusni to give her lecture. Prof, you can share your screen now.
Assalamualaikum and a very good morning. Thank you very much to the organizing committee for inviting me to speak in this webinar. Can you see my screen?
Yes, Prof, you can see your screen clearly.
But it's in the, not in PowerPoint, right? And not in slide.
Yes, not in the slide.
So is it in the slideshow mode now?
Yes, it is in the slideshow mode now.
Okay. All right. So let us begin the case for today. So we have a 72-year-old female who was referred to our hospital last year for anemia and thrombocytopenia. And she currently complains of easy bruising and fatigue. However, she denied any symptoms and no history of taking traditional medicine. She has previous history of ICU admission in Penang Hospital, in a hospital in Penang due to AGE for, and subsequently was under HPJ follow-up for anemia and thrombocytopenia. I think around 2019, she was offered BMAT then, but patient refused and went to Columbia Hospital in February 2024 fever. She also has chronic lung disease and under follow-up ENT for, I'm not sure what is the conditions. Clinically, on examination, she has liver hepatosplenomegaly. However, there is no lymphadenopathy. So there were some laboratory investigations in earlier hospital in HPJ, July 2019, which shows a severe macrocytic anemia with a normal B12 folate, LFT and TFT, and subsequently in February, July, and in August was in Columbia Hospital, if I'm not mistaken, in which she has moderate to mild anemia. Okay. And when she came into us in HSAS on November, she actually has leukocytosis with anemia, severe anemia, and started to have thrombocytopenia. Okay. And other investigations done, LFT, RP were normal, and high ferritin with high B12. Okay. And further investigations was performed on 16 November, where the leukocytosis is becoming higher with hemoglobin. I think she was transfused and low platelet count. All right, so I'm going to show you the slide. Okay. Oops. Sorry, I think I have to unshare this one and I have to unshare this one and then share another screen. Sorry for that. Or maybe I can share it from here. All right, okay. So this is, can you see the slide?
Not yet, Prof.
Not yet, yeah. So I think I have to unshare it. This one. Oh, okay. Can you see the slide now?
Not yet, Prof. No, not yet.
What is showing on the screen?
It's like you're not sharing anything because all I'm seeing are the participants.
Oh, okay. All right. Okay, right. I'll try this one.
Okay, it's on now, Prof.
It's on, yeah? All right,
Yep.
good. All right, so this is the full blood picture. Can you see the slides moving?
Yes, Prof, we can see it.
All right, okay, good. So this is the full blood picture of the patients, which shows dimorphic red cells, right, with marked adenosine and you see there is leukocytosis mainly of the neutrophils and the myelocytes. Okay, and if you can see that the neutrophils are dysplastic, okay, some are hypolobated, showing pseudopelgiform and with hypogranulations. And you can also see myelocytes and the immature granulocytes. On count, there are about more than 20% of those. And the platelets are also low, and you don't see any platelet clumping. And there's also quite a significant nucleated red cells in this peripheral blood film. Okay, so let's try. I'll show you the marrow. So this is the bone marrow for this patient. For a 71 years old, is hypercellular fragment and hypercellular cell trail, and there were not many mega around, but what we see is mainly the granulocytic and erythroid hyperplasia. There are quite an increasing number of pro-erythroblasts seen in this patient, and we do see the granulocytic this granulopoiesis dysplasia and also mild megaloblastic changes, megaloblastoid changes in this bone marrow. You can see the erythroid precursors, the islands. Okay, yeah. And however, the blast count were around 2% for this patient. Okay. And next, I'm going to show you the Trifine. Trifine is a short course. It's about 9 millimeter in length. And there were, I would say that it was inadequate. However, from the two, I would say approximately Trifine two fragments that we saw, they are hypercellular and so they were granulopoiesis and erythropoiesis hyperplasia similarly seen as in the bone marrow. And you can see the immature granulopoiesis are at the paratrabecular area, and if you go in, you can see erythropoiesis hyperplasia. I'm not sure how it appears in the screen, but in my screen, you can see also a few mitosis figures and erythroids. Okay, erythroid island and precursors. They were not. Let's see, make a correction. Okay. If you can see, these are some of the megakaryocytes, yeah, in the intertrabecular region. Some are hypolobated. I think it will be better seen in the special stain later. There were no increase in patient and there were no clear ellipse in any of the Okay, so let's go back to this slide. Oh, I have to stop sharing. Share. Go to slideshow. So these are some of the captured peripheral blood film and some of the bone marrow, as we saw earlier just now, and the trifine. Okay. And the retics was around 1 to 2, and there were no increase in CD34, CD3, and CD20 were scattered in the trifines. E-cadherin shows increase of the pro-erythroblast for about, I think, 20%, similar like what we saw in the bone marrow. And this is the CD61, which shows the megakaryocytes, mainly showing hypolobated this megakaryopoiesis. And this is a P53 staining to show the varying intensity of the erythroblast. As for the patient's progress, so if you can see, patient was transfused back cell before the bone marrow. Bone marrow was performed here. And then another pack cells in late December last year, and patient was started on hydroxyurea around December, early December, and was reduced to 500 milligram alternate day. So the case is NMM. If you can see, the myeloproliferative bit is cytosis, where there is neutrophil leukocytosis and hyperplasia of granulopoiesis and erythroid line. And you can see the myelodysplastic feature, where there is cytopenia of the red cells and platelet, with dysgranulopoiesis showing pseudopelgia and hypogranular and hypokaryopoiesis features. So our case actually best fit. I would say best fit because we don't have a clear, I would say adequate information to give a confirmatory diagnosis. So we put in a best fit of MDS-MPN with neutrophilia, which is a very group of myeloid neoplastic disease characterized by overlapping features of myelodysplastic and myeloproliferative neoplasm. And in the WHO 2022 and ICC classification is actually called myelodysplastic myeloproliferative neoplasm with neutrophilia, and ICC is atypical chronic myeloid leukemia. Oops. I have to stop sharing because there is a little bit of problem. Sorry for that. So MDS-MPN neoplasm is a neoplasm where the myeloproliferative component coexists with ineffective hemopoiesis, leading to cytopenia. So there are two keywords, there is cytopenia and cytosis, that we have to consider. For MDS-MPN with neutrophilia or chronic myeloid leukemia, is a rare clonal hemopoietic stem cells disorder is usually in elderly in presentation between 60 to 76 years old. And as you remember, our patient is 71 or 72 years old now. And estimated incidence is 1 out of 100 cases of BCR ABL positive CML, and is about 1 in 1 million person per year. For gender, is initially is female more than male, but a recent larger cohort from the study shows that male is more than female, but in our case, it's a female patient. The clinical features would be similar to BCR-ABL positive CML, in which there is splenomegaly and neutrophilic leukocytosis. And what we saw in our patient, there is splenomegaly and neutrophils leukocytosis. And it predominantly affect the neutrophilic line, with circulating immature granulocytic should be more than 10%, which we have in our patient. And there is prominent granulocytic dysplasia, which we saw in our patient. This is the criteria for MDS-MPN with neutrophilia. And in our patient, we saw this, and they did a molecular test in December, in which there is no detections of BCR-ABL and JAK2. However, MPL and reticulin was not done, unfortunately. For the diagnosis is still challenging and relies primarily on morphology, and you have to have absence of Philadelphia chromosome, and we saw that in our patient, and there is presence of dysgranulopoiesis in bone marrow and peripheral blood, and this is considered a major criteria to distinguish from BCR-ABL positive CML. Eosinophil is not as prominent as in CML, and as in our patient, we see about 0.8%. And you do have to consider also CMML, which is one of the MDS-MPN also, but you have to have a monocyte of more than 10% for CMML. But in these patients, we have it less than 10%, 6.2%. And proportion of immature granulocytes with significant dysplasia has to be there. This is to differentiate with chronic neutrophilic leukemia, in which there will be high white blood cells with more than 80% of segmented neutrophils, which we don't see in this patient. For the bone marrow findings, you have to have hypercellular bone marrow with myeloid hyperplasia and prominent granulocytic dysplasia. You may also see trilineage dysplasia, but in our case, we do see mild dyserythropoiesis and this megakaryopoiesis. For the myeloproliferative gene, that is JAK2, reticulin, and MPL, is usually associated with MPN disorders, and it has to be absent in MDS-MPN with neutrophilia. So in this case, because we don't do calreticulin and MPL, so we only do JAK2, so we don't really fulfill the criteria. So if you have triple negative MPN, then this becomes very difficult, and we have to do genetic analysis to facilitate the diagnosis for that. So for MDS-MPN neutrophilia, MDS-MPN with neutrophilia, in 1/3 of cases, there are recurrent mutations of ETNK1 and ZBP1, and in association with ASXL1, which has been linked to more aggressive disease. We don't do this in our patient, unfortunately. And other mutations that they have found is NRAS and KRAS of about 11 to 27%, SRSF2, EZH2, RANZI, TET2, and CBL. And for WHO criteria, the recent additions support somatic mutation of ASXL1 and ETNK1 for diagnosis. But for ICC, they focus on somatic mutation involving ASXL1 and ZBP1. So I think soon maybe in the newer editions later on, maybe 6th edition, the ZBP1, ETNK1 and ASXL1 probably will become a criteria for diagnosis. If you can see, we did P53 in our case because P53 has been demonstrated to play an important role in promoting cell cycle arrest in hematopoietic stem cell. So these researchers actually have a research question whether a strong P53 expression by IHC is useful in supporting presence of neoplastic erythroid precursors like PEL versus weak or absent P53 in non-neoplastic erythroid condition. So they did they compare this, pure erythroid leukemia cases, and out of 27, 26 strong, uniform, and diffuse staining of chronoblast compared to normal and reactive control. And in this paper, strong P53 positivity is unique to PEL and can discriminate benign erythroid hyperplasia. So this is to show you the grading of P53 immunohistochemistry, 0%, 1%, 2%, and 3%. And this is to show the normal and reactive erythroid hyperplasia compared to pure erythroid leukemia in this research. So I think that's for today's the knowledge sharing with regards to MPS, MDN neutrophilia, and I would like to thank my staffs in hematology unit, pathology laboratory, HSAS, and my medical officers. And thank you for that.
Thank you very much, Associate Prof. Dr. Yusni, for your very interesting presentation. Is there any questions from the floor? Prof, I do have a couple of questions myself. Firstly, in the slide where you showed the E-cadherin IHC, you mentioned the E-cadherin was 20%. How would you quantitate the positivity for E-cadherin on a Trifine?
It's actually more of eyeballing.
I see. So it's like semi-quantitative.
Yeah, it's like semi-quantitative. And then
see.
you just compare it to the percentage in the SP rates. So it's about the same. Yeah.
So in MDS, MPN with neutrophilia, the erythroid component would have more pro-erythroblast component, is it, as opposed to the later stage of
Not really. That's why I said it is not a feature. So I'm not sure whether they have given some medications which probably increase the erythroid component, because that's why initially we were very worried that is erythroid leukemia. So and then we don't have immunophenotyping. No, I mean the primary team didn't send for immunophenotyping, I think because clotted, I'm not sure. So they did immunophenotyping from the peripheral blood, which shows about 2% myeloblast. So because of that, that's why we did P53 in the Trifine to make.
Okay.
we are not dealing with, or we don't miss PEL.
Yeah.
So in MDS and MPN neutrophilia, there is usually no erythroid hyperplasia. So for these patients, I am not very sure. Probably they give erythropoietin that they don't mention to us. Maybe yes, which I don't get it from the primary
I
information.
see, I see. Okay.
Uh,
There is a question from the chat box from Dr. Nurhana. In case of MDS, can the P53 IHC stain show homogeneous strong positivity?
Actually, about the P53, what I get from this paper is in any other conditions apart from PEL, it will show a very, it won't show a strong staining. So probably in MDS, it will be showing low, it's not strong like the PEL. So maybe one or two the grading of the erythroid. So I don't think in any other conditions it will be showing a strong P53 staining as we see in erythroid leukemia.
Prof. Okay. Is there any other questions? If you can unmute yourself and ask the speaker directly.
I'm still learning also because I don't, I think this is my first time seeing atypical CML. So it was quite a tough moment for us to to come out and then give the diagnosis to the clinical team. Yeah.
Yes, actually, we also had a recent case of we are unsure whether it's PEL or not, and we also did have to do the P53 IHC.
Mm. I mean, I
So
was lucky to have P53 in our in our
yes,
center.
that's
Because
true.
they have limited IHC support for the moment for now.
Okay, if there is no more questions, I just would like to conclude our case. So, in cases with mixture of cytopenias and cytosis, we have to look at the morphology, see if there's a presence of dysplasia as well. And in this disease, we need to have more than 10% of dysplasia, right, Prof, to
Yeah,
differentiate with chronic neutrophilic leukemia.
correct.
And And we also have to do molecular testing, at least for BCR-ABL, JAK2, MIPL, and CALR.
Yes,
If they are negative, um,
that's
then
what the
yeah,
best would be to do the genetic analysis. You see, because that what was has been found by other researchers. The genetic analysis, I think, would be helpful in these patients, in this kind of patient. Yes.
what about cytogenetic, Prof? Do we have to
Uh,
we have to exclude line
from my
22?
reading, from my limited reading, they don't say about the cytogenetic, so I'm not very sure. I don't see that in the reading in the paper. Yeah. If anyone has any information, it would be wonderful to share.
Does anybody have any comments or any sharing experience that we can share today? Dr. Faiz, would you like to give a few thoughts?
Assalamualaikum warahmatullahi wabarakatuh. Good morning. Um, we 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 also have this kind of dilemma several times in our center, and with limited accelerator. So sometimes we just kita just terpaksa lah bagi based on the morphology and based on based on whatever I see that we have. Yes, I acknowledge that P53 is useful, especially when we want to identify whether this reactive or just neoplastic. on a plastic electrolyte series. I mean, I have agree. I have to agree with you, Prof. That what ni Husni. Kes macam ni tu dilema kita, susah duduk termenung tengok, but then we have to come up with a quick diagnosis um, so that they can start treating the patient. Itulah the molecular test pun in our center pun quite limited, and I hope that we can expand that, we can offer in the near future for MDS, so that we can happily differentiate MDS, MPN, or whatnot.
Yes.
Always a diagnostic dilemma in this kind of cases.
Very true. Very true.
Thank you for the presentation.
Alright.
Okay, thank you so much, Dr. Faiz, for your input. So we have come to the end of our webinar. I would like to thank Associate Prof. Dr. Yusni Rahayu for that very interesting presentation, and for everyone for listening. And I hope we can all benefit from the webinar. Please keep an eye out on our next webinar, which we will send the details through the flyers as usual. And if you haven't filled in the attendance form, please fill in the attendance form, as we need the details for CPD points application. So with that, we'd like to thank everyone, and we can end our meeting with Tasbih Kafarah and Surah Quran. Thank you so much, everyone.